Hi, everyone. This is Caroline from Fiat Integrative Health in Franklin, Tennessee, and you're listening to the Fiat Health Podcast. We believe that now more than ever, the healthcare industry has become a place of confusion. And over the years, we have been asked countless questions about what true health and integration for the whole person looks like. Join us every other week as we explore topics ranging from primary care and women's health to counseling and spiritual health. We're so glad you're here. Hey, everybody. Welcome back to the Fiat Health Podcast. My name is Caroline, and today I am joined by Amanda. How are you doing, Amanda?
I'm good, Caroline. How are you?
I'm good. We are in the heat of the summer and prepping for school. We were just commiserating over school prep for kids.
Oh, so much.
You have 4 kids.
Yes.
And they're all school age now, right?
They all are, and they're all in between kindergarten and 8th grade. So It's a lot of stuff this year.
A lot. Exciting, but a lot.
Yes.
Today, though, we are going to talk about endometriosis. And I'm really excited because there's a lot that I don't know about endometriosis, but I see it all the time on social media with all of the health people, especially if you follow like Dr. Jolene Brighton. She's really big on endometriosis. So I'm just excited for you to share your wealth of knowledge, Amanda, and answer some questions.
Absolutely. Well, endometriosis is a topic that I enjoy talking about because it does affect so many of my patients and it goes undiagnosed so often. I feel like I have a conversation about endo every week with somebody.
Mm-hmm. Yeah, it's kind of this obscure thing that people have no idea exists, I feel like. And then they come in and it's like, you might have endometriosis. And they're like, what the heck is that?
Absolutely. It is definitely something that comes as a surprise to a lot of women. And it is a huge source of infertility. And so often, always, within the first 4 months of an infertility workup, we're having an endo conversation in some capacity.
Yeah. Okay. Well, tell us, what exactly is endometriosis?
Well, endometriosis is a multi-system chronic inflammatory disease. So it does affect about 200 million people worldwide. And that's probably an underestimation because of how underdiagnosed it is. The most defining characteristic is endometrial-like tissue that grows outside of the uterus. So the uterine lining is made up of 2 types of cells, endometrial and stromal cells. And these cells respond to hormones every month. And so as estrogen rises, the uterine lining gets bigger. As progesterone rises, the uterine lining becomes more nutritious, ready for implantation. And the tissue outside the uterus, the endometriosis, responds in the same way. And so if you think about what happens to the uterine lining, you don't want that happening everywhere else in your body. And endometriosis can be found virtually anywhere in the body. And so as those tissues outside the uterus respond to hormones, you get ongoing pain and an inflammatory response. And so it is a very painful multi-system condition.
And the tissues weren't supposed to be there.
They are not supposed to be there. No. And most people think endometriosis, it's growing on the outside of my uterus, or, it's, growing in the pelvic cavity, but it can grow anywhere, like the diaphragm, around the heart. All over, you can have endometriosis.
Yeah, I think I was first kind of introduced to that when I was talking to an endosurgeon. And she was like, oh, yeah, well, when we do surgery, we also have to have GI in the room. And sometimes we have to have cardiac. And because you can go in and find endo anywhere. And I was just like, oh my gosh, I had no idea.
Yes. And that was a big surprise to me early in practice. Like I met a patient with stage 4 endo and they had to leave her chest endo in because it was around her heart and it was too dangerous to operate. And so she would have chest pain with her periods. And I had never heard of that until I had met her. So.
Wow. So what kind of symptoms do we look for to think like, oh, maybe I do have endo?
So there's definitely a broad gamut of symptoms of endo. And that's actually one of the difficulties with diagnosis is the symptoms can be broad and vague. So period pain is not normal. That is something that we like to emphasize in restorative reproductive medicine because so often women are dismissed in standard medical practice as, here's a birth control pill to deal with your period pain. Pain is just part of periods, this sort of thing. And the truth is, no, Periods should be something that doesn't disrupt your everyday life. It should not cause days and days of PMS. 1 or 2 of mild symptoms is fine as hormones crash, but you should not feel terrible for 1-2 weeks before your period. You shouldn't miss work. You shouldn't have to cancel plans. These are all things that are not normal. So endo can come with classic symptoms like pelvic pain or period pain, painful intercourse, bowel and bladder issues, especially like diarrhea on your period. You can also have sciatic nerve pain. That's one of the vague ones. Shoulder, chest pain. Some women in extreme cases have like collapsed lungs from endometriosis.
Oh, wow.
Severe bloating, constipation, nausea, vomiting, rectal bleeding, painful bowel movements or urination. Kidney issues like low kidney function or obstruction have happened with endo. Of course, infertility, and sometimes infertility is caused by silent endo, which is when endometriosis is present, causing enough inflammation to get in the way of fertility, but it's not causing other symptoms. Endo also causes miscarriage, pregnancy complications, fatigue, headaches, migraines. And the big one is depression, anxiety, and PMDD. They also have, if you have endo, you have a higher risk of these conditions. And sometimes they are much more severe because of the hormone imbalance that naturally comes from endometriosis.
And all of that is because there's this tissue in places that it shouldn't be.
Exactly.
And the tissue itself is responding to the hormone changes.
Exactly.
Right? Yeah.
Exactly.
Wild. So what's like you said, the cardiac pain or the cardiac, what's some other like really interesting cases that you've seen of endometriosis?
So we've definitely seen our fair share of tubal pregnancies and chemical pregnancies caused by endometriosis. And in those particular cases, I have a lot of very cool situations where the patient went for surgery and they got pregnant and had a full-term baby after surgery. Because with a good surgeon, you can correct those things a lot of times. But one of the interesting ones that came up a couple years ago for me is there's a patient who had endo and PCOS, and there's a strong link between endo and PCOS. More people have PCOS alone than endo and PCOS, but there is some thought in some circles that 50% of people with diagnosed endometriosis also have PCOS. So there's a strong link. So this patient had a long history of chemical and tubal pregnancies only. And she went in for surgery and her ovaries, which were overgrown from the PCOS, had embedded into the floor of her pelvis. So the physician actually had to dig them out, almost like he was digging them out of holes and suspend them. And she was able to go on and get pregnant naturally and have an intrauterine pregnancy for the first time after surgery. But I thought that was a really interesting case with the ovaries embedded, where they had to pull them out of holes.
Yeah. Wow. Fascinating. So what exactly causes endometriosis?
It's not fully understood. There's likely a lot of different factors: genetics, environmental, immune system issues, epigenetic, hormone. There are links to high stress or abuse in childhood, but it's not that every endometriosis patient has that in their history. There's just a correlation with it in a lot of the research. And then, of course, if you have a close relative with endo, you're 7 times more likely to have it. Mast cell activation syndrome is another one that doesn't quite get a lot of play, but one of my mentors believes that that is one of the root causes of endometriosis. And I think it's a really interesting theory because so many of my endo patients have mast cell activation syndrome. And so that is an interesting one, which would affect or be caused by an immune system issue.
Yeah. And what about like how prevalent in the US is endometriosis, or maybe even worldwide? Maybe we have those stats too, and I know you touched on it a little bit earlier.
Yeah, so 200 million people worldwide, and up to 73% of young women with period pain have endometriosis. And there is some thought that it's 50% of infertility patients. In restorative reproductive medicine, I would actually guess it's more than that.
More than 50%?
Yes, because the endometriosis as a condition is what most of our long haul infertility patients have. And so a lot of times it doesn't get diagnosed till 5 to 12 years, which is the average time to diagnosis.
What?
It's absolutely crazy.
Wow.
And I can tell you story after story of women who come into my office who have had symptoms for sometimes 10 to 15 years, and they've just been blown off by their OB, blown off by their other providers, put on birth control. And sometimes they're very upset because nobody ever told them this. Almost 100% of my IVF failure patients have endometriosis. In fact, I cannot think of a single one who doesn't.
So IVF doesn't work up for endo at all?
Not typically, unless they can't get their process done on its own. Like they will try IVF first, typically, before they send for an endometriosis evaluation. So sadly, a lot of these women have had period pain for years. They fail IVF, and sometimes they're sent for surgery, but other times, especially if they don't have significant pain, they're told, well, there's nothing more we can do. You can do donor eggs or, something like that, or, try surrogacy or something like that. I mean, there's a lot of really extreme measures that are recommended before endosurgery, which is sad.
Yeah.
Because a lot of times they don't know what's wrong, and there's a very real thing that's wrong.
And they're still having pain.
They're still having pain. Endo also comes with a low egg count. Most of the time, someone with strictly endo. PCOS comes with a higher egg count on average. And so if you have the two, you can't always tell from the egg count which condition is present. But in strictly endometriosis patients, they do typically have low egg count, which for us in restorative reproductive medicine, we're like, who cares? You just need one egg for a baby. So, let's go. But in IVF, that is something they get lectured about. There's a lot of shame that goes into that. I don't have enough eggs for this process or whatever. And it's because of the endo, but there's no explanation given. They're given the unexplained infertility diagnosis. And in restorative reproductive medicine, we consider unexplained infertility as just uninvestigated infertility. We always find a reason.
Yeah. So tell me, how would you get diagnosed with endometriosis?
This is part of why it takes so long to get diagnosed, is that gold standard diagnosis is through laparoscopy, which is surgery.
So all the symptoms are there that they probably have endo.
Yes.
And the only way to look into it is through laparoscopy.
It's through laparoscopy.
Are there now I saw, because I don't know if you saw on social media, like that guy who tries to be super healthy. Have you seen this? Where he's like wants to live forever and he spends a bunch of money.
I've heard about him. Okay. Yeah.
So his girlfriend or partner or something has endometriosis.
Yeah.
So they were talking about this blood test it's not fully approved or it's experimental or whatever.
Yeah.
That maybe has some promise for potentially.
There's some of that, especially in Europe. They have tests that can be done that will screen for endometriosis without surgery or without MRI, that kind of thing. I looked into it, and because it's not FDA approved here, you can't get access to it. But it also, who knows if it's really diagnostic. And in the grand scheme of things, if they have endo, which I've only ever had one patient in my entire career go to surgery and not have endo when I told them I thought they had it.
Mm-hmm.
They can take it out on the spot during surgery.
Right. So you're going to have to go do surgery.
You're going to have to do surgery anyway. So it makes sense to just take it out.
Yeah. Yeah.
And so the diagnostic laparoscopy is kind of the big hurdle. And so most of the time for my patients, we'll do 4 months of treatment with fertility drugs or, luteal phase treatment. Whatever we see from the labs needs to be done. And then after 4 months, we start having the endometriosis conversation if I think it's going on. I mean, sometimes they have a very straightforward history where I really don't think that's what's happening. And so maybe we'll go 8 months or 9 months of fertility treatment. But at some point in a infertility evaluation and treatment, we do have an endometriosis conversation, because I have so many stories of people who swore they could have never had it because of their symptoms, and they always come up positive when they go to surgery.
And what does a laparoscopy look like for people who, that's a foreign language,
Definitely. So laparoscopy typically is a robotic surgery in the best case scenario, where the surgeon is using a robot to excise the endometriosis lesions. There's definitely some surgeons who are still doing ablation, but that is not the gold standard anymore. And so excision is the gold standard. And with the Da Vinci robot, you get a lot of precision. So because it is laparoscopic, you typically get pretty small surgical scars. But depending on how invasive it is, in worst case scenarios, stage 3 or 4, one of my stage 4 patients had to have a bowel resection during it. So they had to bring in a GI surgeon. She had a completely adhered ovary, which means it was so covered in scar tissue, it looked like it was saran wrapped together.
Wow.
And so they had to basically reconstruct her ovary.
Wow.
In extreme situations, it can be a pretty detailed surgery where you're bringing in extra surgeons and things like that. But ultimately, it should still be laparoscopic.
Now, I know that we have a list of people that we refer to for this because not all endosurgeons are created equal, right?
Yes, that's one of my favorite things to say.
Glad I hit the nail on the head there.
So at Fiat, we practice restorative reproductive medicine, which means we're trying to restore the female anatomy to the way it was created to be, which in turn restores fertility, but also restores health, restores function. And so surgeons are trained differently depending on what their overall desired outcome is. So a lot of people are doing endometriosis surgery to get rid of endometriosis pain, but their plan is that they'll do IVF or something like that afterwards. And so some surgeons just assume that in cases of infertility, they might try like 3-4 months of Clomid or letrozole and then go to the IVF clinic. And so not every surgeon is trying to do the maximum amount to restore natural function. And that's not to be mean or to be critical. It's just you want your surgeon to have the same end game desire as you. And so if you are going to do restorative reproductive medicine, you want your surgeon to be trained in what's called plastic surgery of the pelvis, where they literally treat the pelvis like they would your face. And so they have techniques to eliminate scar tissue. Sometimes, in some cases, they'll even use things like Gore-Tex to prevent scar tissue and go back in and take it out after surgery. They can reconstruct tubes, cannulate tubes, reconstruct ovaries. And so who you see as an endometriosis surgeon really does matter because you want them to share your same goals.
Yeah, because some endosurgeons too will be like, oh, we'll just like take this ovary out, right?
Right. Well, and I had this happen a couple years ago where a surgeon, who's a very good surgeon, told my patient it's standard of care to cut out a fallopian tube if it's damaged. And I looked it up and she was absolutely right. That is standard of care. But the restorative surgeons are not doing that. They're saving it if at all possible, or cannulating it, doing whatever they can to preserve it rather than just cutting it out. And so I did have a conversation with some of our restorative surgeons who we refer to, asking what they would do in that situation. And they said they would definitely work as hard as they could not to cut the tube out. Fortunately, the patient didn't need that. The tubes were fine. But it really gave me pause to think through who I'm referring to and what our, outcomes, what our desired outcomes are, because that was a pretty shocking realization for me.
Yeah, because some of those endosurgeries, you don't know what you're walking into. And so it can last anywhere from like a couple hours to like all day, right?
Yes. And some people have to go back for multiple surgeries. It is not very common. And we've actually been having a discussion in women's health about this, referring to surgeons who do not do multiple surgeries routinely is important as well. Because, surgery it's a risk.
It's a big deal.
And so you don't want to have to go back for surgery more often than you need to.
Right. Now, what other, besides surgery and excision, which I know is like mostly has to happen, what are other things around that that we do to help treat endometriosis?
Absolutely. So in standard Western medicine, there's a lot of hormone suppression that goes on with endo, which is birth control for endometriosis. Now, we don't prescribe birth control. So a lot of what we do is trying to restore function, but also help reduce pain without the use of birth control. So I say that because if you talk to your general OB on the street, they probably are using birth control. And that's not that they're doing something against standard of care. It's just our goals in restorative reproductive medicine are to leave birth control out of the equation.
Right. Right. It's not prescribing just because it's birth control. It's because it's not actually addressing what's going on.
Exactly. So we do endo diets. There's a really good one. We'll link it in the show notes. From Dr. Young, who's one of our restorative surgeons in St. Louis. He has an amazing diet guide for endo. It's one of the best ones I've ever seen. So I will link it in the show notes. It's essentially gluten, dairy, and sugar-free because the goal is to reduce inflammation as much as possible. Sometimes, though, these diets and this long-term lifestyle changes can be really hard. So sometimes having a nutrition consult or a nutritionist on board to help, especially a restorative nutritionist who really understands what's going on, can be helpful because diet does matter with endometriosis. Mental health also matters, and mental health can be such a big deal because these are the patients who have probably already been through years of fertility treatment before they realize that they have endometriosis. And then just because you have surgery does not mean magically pregnancy is going to occur right after. And a lot of people are under the misconception that that's going to happen. And for some, it does. I mean, we definitely have some great stories, the next cycle or 2 cycles later. But in the majority of the population, they still have to work at it. And there's still obstacles in the way. And so that can be very hard in terms of mental health, depression, and anxiety. So having good mental health support on board is important. When it comes to medical interventions, we, of course, are avoiding birth control as much as we can, trying to find the root cause of their symptoms. And some of that comes with treatments like N-acetylcysteine or naltrexone is one of my favorites for endometriosis because it gets at that inflammatory piece. Cabergoline, because a lot of endo patients do have elevated prolactin, and cabergoline tends to help with their pain as well as just help with their hormone function because it is suppressed or altered by high prolactin. So those are some things. We also do, lots of vitamins, probiotics. Sometimes these patients have a propensity towards endometrial inflammation or infection as well. And so making sure that we're addressing that as well. And then progesterone to offset estrogen dominance, because with endo being present, these patients have high estrogen levels very often, and the progesterone is the antagonist of that. So it prevents some of the complications that just come from that hormone imbalance.
What is the typical recurrence of endometriosis?
You mean like after surgery?
Yeah, if you got it surgically removed, how often is it coming back? Because we just don't know what's causing these lesions to occur. So do they often come back, or are there ways that have been shown to kind of prevent that from happening again?
You can definitely get hormones in line, and it helps with preventing the lesions from returning. It really depends on the patient and the surgeon. Like every surgeon has their statistics, right, on, what their recurrence rate is. One of the surgeons on our list has a 85% non-reoccurrence rate is what he quotes. But again, it's different with everybody. In terms of my experience with patients, sometimes the stage 4 patients are getting regrowth faster and require multiple surgeries. So it really does just depend on the patient and the surgeon. But pelvic floor therapy is also very helpful after surgery, because a lot of times just because you remove the endo doesn't mean that the scar tissue, the muscles, everything needs some therapy to get back to a place where they can be without pain. And so having a good pelvic floor therapist can be really, really helpful.
And I think for anyone who's never experienced pelvic floor PT, maybe you could explain a little as to what that looks like. I know I've had pelvic floor PT, but I haven't had endometriosis. But my idea before going to a really great PT was like, they're just going to give me a band and tell me to do exercises, which is not the case for this kind of PT.
No, a lot of times I've had a couple patients go where they have complete pain relief afterwards. There is, external work, internal work, and a lot of the exercises, especially, and of course, we have access to an amazing pelvic floor PT here at Fiat. A lot of times, if you have a very good therapist who knows what she's doing, even before surgery, they can get some pain relief.
Pain relief. Yeah, I feel like they do a lot of manual work where they're helping with scar tissue or, lesions, and they're just so incredible. They're like magicians.
Yes. That is what my patients say, is that it's like this miracle that occurs.
Okay, awesome. Well, maybe what are some of the like nutritional things that are like best practice and things that if you're like either you have endometriosis or you suspect you have endometriosis that you recommend for anybody who gets diagnosed with it?
Definitely the anti-inflammatory diet, gluten, dairy, and sugar-free. I've linked a couple nutritionists that we have referred to before that we can put in the show notes. We're also hoping to start nutrition services coming soon here at Fiat, which I'm very excited about.
This is like, what is it when people give away the movie ending or whatever?
Yeah, it's a spoiler.
Spoiler, yeah. Spoiler alert. We will have nutrition soon.
Yes, which I recently spoke at another place about this, and I definitely told them that because I was like, this is coming. We need to be excited about this. And of course, if pain is not relieved with medical treatment, that surgery is the best bet. That's something that can give good quality of life and drastically improve natural fertility. Of course, the sooner you do surgery, the better, because natural fertility does decline over time. And so the earlier surgery is done, the better the fertility outcomes. And that plays true in my practice time and time.
And I know I've had patients or friends who have come and seen you. And I remember one of them being like, yeah, she like recommended I go get evaluated for surgery. Like seemed really drastic. And I, on the other side of it, knowing what I know, I'm like, yeah, I understand that, but that it seems drastic. But when you have the people who walk in after 10 years of never being told to go get surgical, a laparoscopy to see what's going on, and they're mad,
Yes.
Why didn't anybody tell me this sooner? It's like two sides of the coin,
It is. I have to be very judicious because I definitely, especially when I first started practicing, jumped the surgery conversation way too soon. And people were like, what is she doing? But it's so important. And 99% of my unexplained infertility patients have endometriosis. Probably more than that, because I'm actually just counting this one who went to surgery once and didn't have it. But every other infertility patient that I have sent for endo surgery had endo. So,
and like you're saying, it's not necessarily the only thing going on.
It's not, but it is as the root cause because it can cause those high prolactin levels, and autoimmune conditions are higher with people with endo, and sometimes thyroid conditions. And if they have PCOS and insulin resistance, these multifactorial things that can go on and cause infertility, they're often all there with the endo.
Right. Too. And it's like, we got to address all of it.
Yeah.
And
I mean, that's what we do in restorative reproductive medicine is we're trying to get the natural goal of a baby, but we're trying to fix everything in the meantime so that health and function can be restored as well. Because it's an absolute disservice to women to let them suffer with period pain and suffer with not knowing. We are in the information age, right? We should know why we're having pain and not just grin and bear it.
Or just, take birth control.
Or just take birth control.
Make it go away.
Exactly. Make it go away for now. But then, and I have so many stories about this, then when you're 30 and you want a baby, that's when you get to find out that you have this diagnosis that's going to hold you back.
Well, any parting words on endometriosis before we close out this episode, Amanda?
I just want to say that restorative reproductive medicine has some amazing options for endometriosis. And so while it does seem like a heavy diagnosis, there's heavy implications to it, there is hope for function to be restored and for quality of life to be restored. And that's just something that I'm very excited about. And that's why I do this.
I love that. Such a message of hope, which I know so many people need on their infertility journey and just journey through period pain and hormonal issues and everything, because it can feel so burdensome and so long and so hard.
Definitely.
Well, thanks for joining me today, Amanda. It's always such a joy.
Thank you, Caroline.
Thanks for listening to this week's episode. To learn more, you can visit our website at fiathealth.org. If you enjoyed this episode and you'd like to help support the podcast, please subscribe to our show on your favorite podcast platform and leave us a review. This helps make the podcast easier to find. Lastly, if you'd like to reach out, ask a question, or suggest a topic for a future show, send us an email at media@fiathealth.org. God bless.